neglected traumas. And how does an old injury differ from a neglected trauma? The tendons and nerves are retracted, and because they are retracted, they have undergone a myostatic contracture, so you can't use them anymore. Joints are stiff, so for them to be treated, you have to overcome the stiffness, which is either splinting or contracture release, and treat it. So one more additional step, and that too not a one-day job, it takes months. Skin contracture, the skin is contracted or it is scarred, so you have to put a flap there, so another 3 months gone. Planes are lost, so if you are going to do a surgery through 2 inches incision, you have to inject more Valant and go into 6 inches area. So planes are lost because you have to start from normal and go into the damaged part. Wounds are maybe infected. So with this all, everything changes when you see an old injury, and it affect the skin, the bones, the various joints, tendons, nerves, and oftentimes it is a combination. And let's take the first combination, and we showed this photograph, but let's see into details, because this patient involves a lot of things that happened. So he had a punctured wound. Just remember the word punctured wound with fracture of the radius and whatever the extent of displacement of the radius, and a unicortical fracture of the ulna. And 3 days later they said no, this was probably compartment syndrome, and the plaster is cut. And sure enough, he had a compartment. Now it is history. It's 3 days. So they still did a debridement. During the process of debridement, they excised the median nerve, they excised the flexor tendons. Fractures were unstable, and therefore they decided to put an external fixator, and you can appreciate the periosteal reaction in this patient. So he is developing osteomyelitis of radius and ulna, and the whole radius sequestrated. When the radius sequestrated, the forearm was hanging on the ulna, and therefore they attempted a single bone forearm, and that unfortunately ended up in a non-union. So now by then he had undergone 14 surgeries, and 14-year-old boy. So now he has a scarred forearm on the volar aspect, median nerve loss, flexor tendon loss, stiff joints, and non-union of the single forearm, and now he has a certificate also. So this is the patient who comes to us. So we identified the problem 1, 2, 3, 4, 5. Rod that was put to create a single bone forearm, it went from the ulna, it went across the carpus, it went from the metacarpal, and it went right up to the distal phalanx. They are square nails which are holding the phalanges in extended position. Sure enough, we withdrew the wire, and now the problem was non-union. So I designed my own fixator. I have a workshop at home, so I made this fixator at home. So there is a hold on the ulna, there is a hold on the metacarpal, and you compress this with a screw. Of course, I use dynamic splints to mobilize the MP joints, and some rubber bands and some glove bands to flex the fingers. So now I have achieved 2 things. First thing, I have stabilized the non-union, it has gone on to union, and I have been able to passively flex the joints. Loss of flexor tendon we discussed in VIC. Either you do a tendon from the front, or now in this case we took a extensor motor from the dorsal aspects. So extensor carpa radialis longus was taken from the dorsal aspect, elongate with plantaris, and brought it to FDP on the patient. He had a scarred hair and the muscles were not working, so I took a free flap. You could use a groin flap to cover the area, and then did a tendon transfer. Sublimis was transferred to profundus, and again a hand was made to work, and it went on to union. On the patient with the third metacarpal which was lost, so I used and not only that, but extensor skin was also scarred, extensor tendon was gone. So what I did, I put an external fixator to elongate the loss, to make up. Once the gap was created, I used osteocutaneous flap. Osteo, that means we took half of the length of the radius between pronator teres and pronator quadratus with the overlying skin, so bone and skin came together, and that was brought in here. And now you will appreciate that bone has become long enough, longer than the other fingers. And so this was the donor area from which this bone was transferred. Another patient with a gap of the phalanx, we did a cross finger flap. As I said, any surgery, deeper surgery can be done only if the overlying quality of the skin is good. So I did a cross finger flap, external fixator to elongate, and the gap was now bone grafted and fixed with K wire, and this was grafted, and this one went on to good union. So we started from a gap in a short finger, and this healed nicely and matured. Then subsequently the only problem remaining was the loss of the extensor tendon. So palmaris longus was lengthened on itself and treated like a claw finger. So this was the patient, and he was in a lift. As he tried to open this lift under construction, he got electrocuted. The index finger was primarily discharged, and it was the turn of the middle finger to be lost, and at this point I was involved. What I was seeing was a bare bone there. There was no flexor tendons visible. There was no nerves there, and from the distal end of the arteries I was not seeing any kind of a bleeding sign there also. So I thought this bone has only the dorsal skin, and this is also going to go. So immediate idea was to save this finger, and I put a groin flap. Now this was done. Now the next thing was sensation. Now I do not know the proximal extent of this nerve damage. Of course distally I am not seeing the nerve, and so for where to you put a bridge between X and Y. I do not know where is X and I don't know where is Y, and therefore I thought the safer option will be to take a neurovascular island bundle from there to harvest the sensate area from here to transfer here. So I transferred a neurovascular island flap from there. So now I have sensation restored on the business end. Pulp is the business end. He may not have sensation here, but at least pulp is the business end of the finger. So restored sensation in the business end. So cover is there, finger has survived, sensation is there, I am getting encouraged, relatives want more, and therefore now having achieved two things, we go to the third thing, reconstruct the flexor tendons. So I put in the silicone rod. Silicone rod, it creates a pseudo sheath because there is a reaction, and then under that we put some tunnels there, and under that a tendon graft, and sure enough it worked. So what was an imminent amputation, we could save this finger and at least useful for computer operation. This patient had a degloving of the upper extremity, and somebody had done only a LD flap to a localized area. Is it serving any purpose? Yes, it helped the surgeon's bank, but did it help the patient? He still has a wrist op, and radial nerve is not there. In a situation like this, we have a two problem. For any tendon transfer, like we have talked in earlier cases here, you have to have a good quality mobile soft supple skin to do any deeper surgery. If overlying skin is not good, any deeper surgery is going to fail. So this is not doing anything. I do not know the extent of radial nerve injury, so there is no point in exploring this radial nerve injury, which is ancient, which is late, and therefore something interesting was observed. The skin is good. And what is this? This is the surface anatomy of a flap. Ulnar artery goes dorsally and goes up for about 2/3 of the forearm. This is a surface marking of the big cus flap. I said, wow, God is kind. So I brought this flap on the dorsal, and now I am ready for a tendon transfer. And the standard tendon transfer we know of, we use there. Here, sure enough, it worked nicely. So we operated one of these patients in a camp, release the contracture, but contractures can recur unless appropriate splinting is not provided. So we provide these splints again. Skin loss. This patient was in ICU for more than 1 month. Also appreciate in 1 month time what is happening. There is a periosteal reaction. So osteomyelitis is sitting in here. So debride this area, and sure enough we did a flap. Posterior interosseous, first dorsal metacarpal artery flap. We brought in a good quality skin, and again we saw 20+ years later, and he has a finger which is useful. Contracture, the web space, we see plenty of them in once you go to rural area, and this kind of flap was this one flap, this second flap, this third flap. As you advance flap number 1 distally, number 2 comes on this side, number 3 comes on this side, and so you have one flap here, second flap here, and third flap here, subsequently followed by splinting. This was a patient with premature epiphyseal closure with a wire across the open physis, and went on to a union only on the radial side. Distal radial ulnar joint is nice and good enough. Now the idea was to take this point here, and what is the distance? This is 4.5 centimeters. So what we did, we created again our own fixator, lengthened it. I have skipped some of the slides. maintaining the distal radial nerve joint, only this was allowed to lengthen and then shorten also, and we had good correction. This is where the surgery started, and this was pronation, supination and flexion extension achieved with single lengthening of only the radial column. Now, the most common problem that we encounter, hyperextended MP joints. It's the commonest problem. Again, as I have been talking, this is a totally avoidable problem by appropriate splinting, and there are plenty of them which are easily available. But if you have this problem, you open it from the dorsal aspect, from the sagittal band, split the sagittal band, and deep to the extensor tendon there is only one thing, the capsule. Excise whatever capsule you can do, and just to the sagittal band. You don't have to split, don't have to touch the extensor tendon. You can cut all 4 of them and you can flex it. You may or may not put a K-wire across them, but see to it you have the MP joint flexed with a dorsal plaster for 5, 7, 8 days, whatever, till the pain subside, and then mobilize them. But important thing is for a long time, so that see to it they are able to maintain it. So in summary, make an inventory of what all is required, what is the deficit, whether it is in the skin, whether it's in the bone, tendons, nerves, or whatever. Just identify 1, 2, 3, 4, make an inventory of what is lost and what is available, from where you are going to get it, and then execute it. The most important thing, you have to have a good quality skin. It is easy to say nothing can be done, you have come late, the first doctor messed up the life, it is not done this way. It's easy to say, but that's an extremely devastating statement. The moment parents or the patient comes to you, he comes with tremendous amount of hope to you. The moment you say this sweeping statement, they are devastated.